Yes, we can start.
Good evening, everyone, and welcome Dr. Parvati, Senior Resident from Department of Anesthesiology, JIPMA, Puducherry. I am one of the screen coordinators for today's session. In today's class, we shall delve into a case discussion on the anesthetic management of an elderly patient for IT femur fracture surgery. Hip fracture is called the last fracture in life because its complication and mortality rates are very high. Anesthetic care of elderly patients is a challenging aspect of perioperative medicine, owing to the physiological changes of aging and the multiple comorbidities they present with. As modern healthcare advances have led to increased life expectancy, we are seeing a growing number of geriatric patients undergoing surgical procedures. Hence, it is essential that we are well prepared to provide optimal anesthetic care for this vulnerable population. Before we move any further, I would like to invoke the blessings of Goddess Saraswati by playing the Saraswati Vandana. Now, I would like to invite our Honorary Secretary of the ISA, Dr. Sukhminder Jeet Singh Bajwa sir, to share a few words with us.
Thank you, Dr. Parvati. Today's topic, I think it's very common, both for the postgraduates as well as for the academicians and also the practitioners. I was watching on that day about the statistics of the 100 plus population in the world, and India is among the first 5 or 6 nations where the life expectancy of 100 plus is now gaining momentum. So if 100 plus is there, if India is on 5th and 6th, I think many patients will be above 65 years, between 65 to 100 years. So that because of the advanced diagnostic and therapeutic facilities available in our nation. So it become equally challenging for the surgical specialties, anesthesia, fraternity, to attend to these people whenever they present for the surgeries, any kind, whether it's under regional or GA or different. And it's becoming an all a different science altogether. The copybooks will be written again. The geriatric anesthesia is going to be a super specialization branch in a few years to come, because moreover, the science is altogether different in the geriatric and the aging population. The pharmacokinetics, the pharmacodynamics, the drug alterations, the requirements, the changing anatomical, physiological structures. So many things are involved in geriatric patient which cannot be taken up lightly as the age advances, because the main thing which we have always seen right from the postgraduate careers, that just like the youngsters, the kids, pediatrics, they are not the young adults. So similarly, we can always say that geriatric, they are, they are not the grown-up adults. So it's altogether a different science with a different pathophysiologies, different physiological functions, and different anesthesia challenges. So I think it's a very apt topic today. So I like that Dr. Parvati to introduce, Parvati and Dr. Asta is also there to introduce the today's faculty.
Thank you, sir. You're a guiding force in our community, and we are honored to have your insights and leadership with us today. Moving ahead, I would like to call upon my co-screen coordinator, Dr. Astha Jindal, to introduce the faculty for today's session.
Good evening to all present. I'd like to introduce our moderators for today's session. Dr. Mahima Batra, Professor Dr. Mahima Batra, she is from Department of Anesthesiology, People's College of Medical Sciences and Research Center in Bhopal. I'd also like to invite Assistant Professor Dr. Ruhi Sharma ma'am. Ma'am is from the same college, and Professor Dr. Akanksha Agarwal ma'am. They have done various publications and have got many awards. There are 3 roles for today's live session. Audience, you please have to keep your mics and videos muted throughout the session. In case of any query, kindly type it in the chat box. All the queries shall be discussed at the end of the session. Now I'd like to hand over the mic to the moderators for today's session. Please.
Good evening, esteemed faculty members, my seniors, colleagues, and dear PG students. On behalf of Department of Anesthesia, PCMS and RC, first I would like to thank this platform and Dr. Bajwa sir especially for giving us this opportunity. Today's topic for discussion is anesthesia management of an elderly patient for femur fracture surgery. As we all know, with better modern healthcare facilities, the life expectancy has increased, leading to rise in geriatric population globally. With rising elderly population, the demand of surgical procedures also increase. And these patients often require a higher level of care than younger patients do during their post-operative period because of their decreased physiological reserve with aging, and which will lead to they are more prone for frequent fall. Hip fractures are the most common trauma-related injuries and most common reason to perform the surgeries in elderly patients. The incidence of hip fracture increases with age. Globally, about 18% of women and 6% men over their lifetime will be impacted by traumatic hip injury. Therefore, it is imperative to know about geriatric physiology, optimization of these patients to reduce morbidity, mortality, and economical burden on society. With this, I welcome you all for today's presentation. Now, Dr. Ruhi will introduce our PG's presenters.
Thank you, ma'am. With an understanding of today's topic, we'll be beginning with the case presentation. The presenters for today are Dr. Nikhil Shukla. He's a third-year resident in the Department of Anesthesiology, People's College. And the second presenter for today is Dr. Shruti Singh Yadav. He's a second-year resident in the Department of Anesthesia. I would request Dr. Nikhil to please begin with the case presentation for the day.
Evening, respected faculties and my dear colleagues. Today I am here to present case on a 73-year-old male with femur fracture. My patient is a 73-year-old Hindu male villager working as a farmer. Patient's complaints being pain and swelling in left hip region since 7 days, inability to move since 7 days. Patient was apparently all right 7 days back when he slipped over the cow dung and fell on the road. Then he developed severe continuous pain in left thigh region. Pain was acute in onset and progressive in nature. Pain was radiating to medial aspect of thigh and aggravated by range of motion in left leg and relieved over intake of analgesics. It was also associated with swelling, redness, difficulty in standing and walking. No history of loss of consciousness, ENT bleed, seizures, and vomit were present. No history of any other injuries were present. Past history, no history suggestive of any medical condition was there. No history of any surgical or anesthetic intervention were there. No history of blood transfusion. No known drug or any other allergy were present. Patient is vegetarian by diet. Appetite, sleep, bowel and bladder were normal. Addiction. Patient has a addiction of BD smoking, 20 pack years. Patient also has a good effort tolerance for age prior to injury, that is MET score more than 4. Patient is conscious and oriented to time, place, and person, and has a lean and thin build. His height was approximately 165 centimeters and weight was approximately 55 kgs. No pellar, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema were present. On monitoring vitals, pulse rate was 62 per minute in left radial artery, regularly regular. Volume and character were normal. No radial and radiofemoral delay were present. All peripheral pulses were palpable. Blood pressure was 154 by 84 mmHg in left arm at supine position. Respiratory rate was 14 breaths per minute, abdominothoracic pattern. Saturation was 98% on room air and patient was afebrile. On airway examination, mouth opening was 3 fingers, Mallampati grade was 2. Patient was partially edentilous. Range of motion of neck were normal. On spine examination, spine was in midline. No local site infection were present. No spinal deformities were present. On systemic examination of cardiovascular system, on inspection, shape of pericardium was normal. Palpation, apex beat was felt at fifth intercostal space. On percussion, normal resonant sound was present. On auscultation, S1, S2 was present. No added sounds were present. In respiratory system, bilateral air entry was present equally. Normal vesicular breathing pattern was there. Chest movement was symmetrical. No added sounds were there. On performing breath holding test, 26 seconds was the reading observed. Abdominal examination, no abnormalities were present in this system. On CNS examination, patient was conscious, oriented to time, place, and person. Higher mental functions were within normal limits. All reflexes were intact. On local examination, redness and swelling over the left hip were present. Tenderness and inability to move left hip joint. No open wounds or bleeding was present. I would also like to take your attention towards frailty. Frailty is characterized by a significant decline in the functional capacity of multiple organ system with an increased vulnerability, stresses, leading to a higher risk of adverse health outcomes, such as falls and disability. Frailty grossly means weakness of the body. Types of frailty score commonly used are Fried phenotype, Frailty index, Modified frailty index, the clinical frailty scale, Frail scale, Edmonton Frail scale, Tilburg frailty indicator, Prisma 7 questionnaire, single physical performance. In this case, we use clinical frailty scale and we got the scoring of 3, where readings are 1 is for very fit, 2 is for well, 3rd is managing well, 4th is vulnerable, 5th is mildly frail, 6th is moderately frail, 6th, 7th is severely frail, 8th is very severely frail, and 9th is terminally ill. Provisional diagnosis of the patient can be 73-year-old male, smoker, with left femur fracture, ASA2 grading and NYHA grading 2. Differential diagnosis can be intratrochanteric femur fracture left leg, neck of femur fracture left leg, and proximal shaft of femur fracture left leg.
Good evening, everyone. Thank you, Nikhil, for the brief history. But a few questions we would like to clarify. Can you just clarify or elaborate on the pack years which you used, how to calculate it, and what's the importance?
Thank you, ma'am. Ma'am, in this, we have calculated pack years. By pack years, we means number of packs consumed in a day multiplied by number of years he has had the habit of consuming bidi or cigarette.
And you have also used a respiratory reserve capacity index, that is breath holding time, right? Can you tell me the importance of its value and how it affects the patient and its physical reserve? And what are the other bedside PFTs? Just enumerate them.
Ma'am, by breath holding time, we mean that we basically are considering cardiopulmonary reserve. And if we are having a value more than 25, that means a person has a normal cardiopulmonary reserve, whereas when a reading of 15 to 25 is recorded, that means a poor cardiopulmonary reserve is present. And if there is a reading of less than 15 seconds, that means very poor cardiopulmonary reserve is there. Other tests that can be performed are Sabrase's single breath count test, Schneider's match blowing test, modified match blowing test, forced expiratory test, de novo whistle blowing test, and cuff test.
Okay. So now we have examined the patient. We know the history of the patient, and now we have to proceed for the management of the patient. But before proceeding for the management, we would like to discuss the physiological changes and pharmacological changes which are present in the geriatric patients. For that, I would like to invite Dr. Shruti, our PG second year, to enlighten us about the different changes present in the body of the elderly patient. Over to you, Shruti.
Thank you, ma'am. It is important for anesthesiologists to understand the differences in pharmacology and physiology in elderly patients to be able to properly use anesthetic drugs and compensate for aging-related functional decline in major organ systems. Effect of aging on cardiovascular system. Arterial hypertrophy leads to increase in afterload. Ventricular hypertrophy results in elevated systolic blood pressure. Loss of cells in the electrical conduction system predisposes to arrhythmias. Loss of sensitivity to catecholamines results in reduced maximum heart rate and heart rate variability. These changes make them increasingly prone to rapid and refractory hypotension and even cardiac arrest. Hence, it is essential that hemodynamic and fluid fluctuations are minimized in the elderly patients. Effect of aging on the respiratory system. Intrinsic and extrinsic factors that influence the respiratory system during aging are described as intrinsic factors are decreased bronchiolar caliber, decreased alveolar surface area, increased lung collagen content, decreased lung elastin content, kyphoscoliosis, increased thoracic cage rigidity, decreased diaphragmatic strength. Extrinsic factors are such as industrial and environmental pollution, smoking, general deconditioning, and coexisting diseases. Functional consequences of the intrinsic and extrinsic factors that influence the respiratory system during aging are decrease in lung elastic recoil, increase in lung compliance, decrease in oxygen diffusing capacity, premature airway closure causing ventilation and perfusion mismatch, and increased alveolar arterial oxygen gradient, small airway closure and gas trapping, decreased expiratory flow rates. With aging, there is difference in lung volumes and capacities as well when compared to younger individuals. Following volumes and capacity increases such as residual volume, functional residual capacity, and closing capacity. But vital capacity, expiratory flows, diffusing capacities, and alveolar to arterial oxygen gradient are reduced. But total lung capacity remains constant even in the elderly age group. Cough effectiveness is reduced in the elderly because of diminished reflex sensitivity and impaired muscle function. The reflex cardiorespiratory responses to hypoxia and hypercarbia, which are mediated via central and peripheral chemoreceptors, are also attenuated in the elderly. The effect on the coagulation system in the elderly. The plasma concentration of many coagulation factors, such as 7th, 5th, 7th, 8th, 9th, as well as von Willebrand factor, is increased, resulting in relatively procoagulant state. Multiple comorbidities like diabetes or cancer confer a prothrombotic state. Incidences of venous thromboembolism and pulmonary embolism thereby increases with age. Thermoregulation in the elderly. Both hyperthermia and hypothermia are poorly tolerated in the elderly. Elderly people have comparatively low resting core temperature. It can be because of neurologic diseases, diabetes, low body weight, smoking, and alcohol. The effect on the gastrointestinal function in the elderly. In liver, there is 25 to 35% decrease in the liver mass, and there is 40% reduction in hepatic blood flow, which is responsible for decrease in first-pass metabolism of several drugs. Non-depolarizing neuromuscular blocking agents such as vecuronium and rocuronium have prolonged effects in the elderly for the same reason. Skeletal and smooth muscle in the esophagus hypertrophies, impairing the coordination of peristalsis. Thereby, gastric emptying of liquids is delayed compared to younger population. Gastroesophageal reflux disorder is more common in elderly with symptoms like dysphagia, vomiting, respiratory symptoms, weight loss, and anemia. Effect on the renal function. There is progressive reduction in renal mass, and there is decline in renal plasma flow and glomerular filtration rate. From the age of 40 years, there is a drop of roughly about 1 ml per minute per meter square in GFR every year. There is therefore delay in drug clearance and prolongation of clinical effects of drugs which require renal excretion. Fluid and electrolyte status should be carefully monitored in the elderly patients as they are more prone to imbalance in the regulation of urine concentration and dyselectrolytemia. Effects of aging on the skeletal system. Age-related decreased muscle mass, bone density, and lubrication of the joints causes stiffness of joints, osteoporosis, frequent fractures of the hip, and functional impairment of bones and joints. Extra care must be given to positioning and padding the patient because of the fragile skin, decreased subcutaneous fat, and poor skin turgor. Impaired rehabilitation and immobility increases chances of thromboembolism and pressure necrosis in the elderly. Neurophysiology of aging. Elderly patients undergoing surgery are more prone for postoperative delirium and postoperative cognitive dysfunction. Postoperative delirium is a syndrome of fluctuating consciousness, inattention, memory impairment, and perceptual abnormalities that occur after a lucid interval of 1 to 3 days after emergence from general anesthesia. The post-operative cognitive dysfunction is more loosely defined as a new temporary decline in cognitive function, manifesting from 1 to 12 months after surgery and potentially lasting to 2 to 3 years. The pathophysiology of both is undetermined. Alteration of various anesthetic drug pharmacology in old age. Aging results in alteration of body composition. The elderly have increased body fat more in elderly women and loss of muscle mass, resulting in decrease in total body water. When comparing body composition from young adult to elderly, total body water in young adult comprises of 60%, while in elderly it decreases to 50%. Total muscle mass in young adult is around 25%, while it decreases to 15% in the elderly. Fat composition remains around 15% in the young adult, which increases to around 35% in the elderly patients. In the elderly, not just patients. The reduction in total body water causes a decrease in the measured central compartmental volume. This results in higher plasma concentration of water-soluble drugs following rapid intravenous bolus injection. The increase in body fat causes increased volume of distribution, resulting in prolonged clinical effects with the use of lipophilic drugs. Decrease in plasma albumin results in increased free fraction of acidic drugs. Drugs have a more pronounced effect in an older patient. It can be because of either pharmacodynamics, in which case the target organ, such as brain, is more sensitive to a given drug tissue level, or pharmacokinetic, in which case a given dose of drug commonly produces higher blood levels in older patients. How does age affects metabolism of drugs? The only way to decrease blood and target organ levels and eliminate the drug's effects is through metabolism. The elimination or metabolic half-life of a drug in the blood equals the volume of distribution divided by the clearance, where clearance represents the amount of blood from which drug is eliminated per minute. The most prominent and consistent pharmacokinetic effect of aging is a decrease in drug metabolism, typically due to both a decrease in clearance and an increase in volume of distribution. The increase in volume of distribution with age is likely due to the increase in body fat. Clearance decreases with age for any drug metabolized by liver or kidney. When drug metabolism is via the liver, decreased liver mass and blood flow to liver will decrease clearance. Drugs with primarily renal elimination will experience decreased metabolism because of reduction in glomerular filtration rate with aging. In addition, most of the times, elderly patients are already on multiple chronic medication. This provides a setup for drug interactions as well as for inhibition of drug metabolism. The net effect on drug metabolism is typically doubling of the elimination half-lives between the old and young adults. To talk about drugs, let's discuss about local anesthetic drugs. Amide local anesthetic agents are hepatically metabolized. Thereby, they may have prolonged effects in elderly age group. Therefore, we require decreased dosing in elderly patients. Elderly patients are at higher risk for local anesthetic systemic toxicity as well. As far as induction agents are concerned, for inhalation agents, there is increased brain sensitivity in elderly patients. Therefore, there is reduced dose requirement and there is around 6% decrease in MAC per decade. For intravenous induction agents such as propofol, etomidate, ketamine, thiopentone, for the same reason as clearance is reduced and metabolism is reduced, therefore the dosing of such agents is also reduced, and even induction and maintenance dose both are to be reduced. Neuromuscular blocking agents and reversal agents such as pancuronium and vecuronium have reduced clearance, therefore require reduced dose requirement. Drugs like atracurium and cisatracurium need no dose modification. So gamma dex in elderly patients has slower onset and has longer time for complete reversal. Takes longer time for complete reversal. Drugs like dexmedetomidine, due to hypoalbuminemia in elderly, requires dose reduction by 33%. Acetaminophen requires no adjustment if normal hepatic functions are within normal limits. Doses of opioids are to be reduced by 50%. For NSAIDs, it is better to decrease the dose by 25 to 50%, and it will be better if we avoid them if GFR is less than 60. Benzodiazepines like midazolam decrease bolus dose by at least 50%. Requires to decrease the bolus dose by at least 50%. With understanding the physiological and pharmacological implications in the elderly, now we will move forward with the questionnaire for the audience. Now I hand over to Dr. Ruhi Sharma ma'am for moving forward with the quiz.
Thank you, Shruti. With an understanding of the physiology and pharmacology that we have discussed, and to see how many of you were actually paying attention to the class, let's go ahead with the quiz. Shruti, please help me out in giving out the questions. I would like to take permission from the class coordinators and have the audience participate in the quiz by answering in the chat box. Let's move on to question number 1. The first question is a multiple choice question, and find the odd one out amongst the following. Which is the decreased parameter in a geriatric patient? Is it decreased arterial elasticity, decreased baroreceptor response, decreased adrenergic activity, or decreased afterload? I request the audience to please answer in the chat box.
I think maximum choices are for C and D, Dr. Ruhi.
The answer for the question is decreased afterload. Actually, the afterload is increased in the geriatric age group. All the other parameters are decreased, that is the arterial elasticity, baroreceptor response, and adrenergic activity are all decreased in the elderly, whereas the afterload is increased. Let's move on to the next question. It is a one-liner. Okay, it is a one-liner. Why are the chances of arrhythmias higher in elderly? I would request all to take 30 seconds to answer this question, and then we'll move on to the next one. Think of whatever the best response you can think of, that why are the arrhythmias higher in elderly age group? We are at 30 seconds. From the answers that we have received, all of you have approximately answered it correctly. The answer is there is fibrosis of the conduction system and loss of SA node cells, which leads to arrhythmias in the elderly patients. Next move question. Again, we'll be taking 30 seconds after completion of the question. Which lung parameters are decreased in geriatrics? Lung elasticity, alveolar surface area, residual volume, maximum breathing capacity. Please take 30 seconds to answer this question starting now. See, the answers that we're getting are a varied, the answers that we have gotten are a varied answers, but the answer is the residual volume is the parameter which is decreased. Rest all of the volume parameters are increased in the elderly patient. Moving to next question. As renal function declines, all of the following declines except blood urea nitrogen, creatinine production, ability to excrete drugs, ability to handle diuretics. Starting 30 seconds now.
We are getting multiple answers here, with the majority coming to creatinine production and ability to excrete drugs.
We are at 30 seconds. Actually, it is the blood urea nitrogen which is not declining. Rest of the factors are declining as the renal function declines. Let's move to next question. The principal pharmacodynamic change that is associated with aging. The pharmacodynamic change is the keyword. Is it arthritis, pulmonary change, lipid solubility, or reduced anesthetic requirement? Which is the pharmacodynamic change that is associated with aging?
We are getting multiple answers for the fourth option, which is reduced anesthetic requirement.
Most of you have answered it correctly, that the reduced anesthetic requirement is the principal pharmacodynamic change. Next question. The onset of drug action in elderly is mainly determined by what? Is it the alveolar ventilation, lipid solubility? Sorry for the typo, it is not A solubility, it is lipid solubility, increased circulation time, or decreased circulation time. Starting.
We are having multiple answers for the lipid solubility. Few answered decreased circulation time.
Actually, the circulation time is increased in the elderly patient, which leads to a delay in the onset of drugs. The initial requirement might increase for some drugs due to the increased circulation time. Let's move on to the next question. The onset of muscle relaxant in the elderly is prolonged because of increased cardiac output, low muscle blood flow, decreased kidney clearance, or decreased hepatic function. You can start answering now.
We're getting a lot of mixed answers for this question here. So multiple people have told low muscle blood flow. They have also answered for decreased kidney clearance and also for decreased hepatic function.
The decreased kidney clearance and decreased hepatic function are the decreased kidney clearance and decreased hepatic function predisposed to prolonged duration of action of the drug, but the onset of muscle relaxant is delayed because the muscle blood flow is low. The answer for this question is B. Let's move on to next question. Again, a one-liner. Please write what you think is the most probable answer. That why is there a profound drop in blood pressure during induction with geriatric patients? We always recommend to have a slow induction in geriatric patient because there might be a precipitous hypertension. Why is there a precipitous hypertension during induction with geriatric patients? Okay, we've got a lot of answers. The best probable answer for this question is the autonomic dysfunction in the elderly patient, which leads to a profound drop in the blood pressure during induction. Moving to next question. Again, we have a one-liner, which is.
Shall we go ahead with the discussion?
I'm just one more question.
Okay.
Which is the most common valvular defect in geriatric patient? Most of you have answered it correctly. The answer is aortic stenosis is the most common valvular defect in geriatric patients. So after having an understanding of the physiology and pharmacology in elderly, we can move ahead with the discussion of the case. I'll hand over the mic back to Kangshan ma'am and Nikhil for further discussion.
Thank you, Dr. Rui, for an interesting question answer session with a very good response from the audience. So coming back to our case discussion. So Dr. Nikhil, let's go ahead with our case. So now we know what are the anesthesia physiological changes in geriatric patients. So let's in way summarize it in the way of what are the anesthesia challenges in your patient. Can you just enumerate them?
Anesthesia complications and management of the case. We'll go system-wise. Cardiovascular system is the most affected system, followed by respiratory, central nervous system, renal system, and patient also come with hypothermia. Cardiovascular system involves risk of myocardial ischemia due to increased oxygen demand. Other conditions can be tachycardia, hypotension, fat embolism syndrome, pulmonary embolism, and DVT. Respiratory system, as we have discussed earlier in physiology, there is increased arterial oxygen tension, increased closing capacity, closing volume, 10% reduction in FeEV1, and lower partial pressure of oxygen. In CNS, patient is prone to post-operative delirium and post-operative cognitive dysfunction. In renal system, acute kidney injury can occur due to decreased perfusion of kidneys during the surgery. Urine output of more than 0.5 mg, 0.5 ml per kg per hour is considered satisfactory. Hypothermia, measures to conserve body heat decreases risk of hypothermia. This may result in prolonged elimination of anesthetic drugs and slow post-operative awakening.
Okay. So in brief, we have again summarized the challenges we have to face in this case. So our optimization, what I feel, or management of anesthesia starts right from the PAC room. Suppose, Nikhil, when this patient is coming to you in the PAC room, so how you will proceed with this patient, how you will counsel him or his relatives, and what all orders you will give to this patient or instructions you will give to this patient.
Ma'am, we'll counsel the patient for anesthetic procedure, nutrition and hydration, cessation of smoking, NBM status, and we'll advise patient for spirometry for improving his pulmonary reserve.
Okay. What about the investigations?
Ma'am, we'll ask the patient to go for a complete blood count, followed by renal function test, liver function test, serum electrolytes, RBS, serology, chest X-ray, ECG, and echo.
Okay, Nikhil, just now, as you told about the cessation of smoking. So, in an elective case, what are the protocols or what are the best policy for cessation of smoking and why?
Ma'am, it is advisable that cessation of smoking should be done at least 12 hours before the surgery, since it helps in reducing carbon monoxide levels. And if patient is here for elective surgery and can wait for 8 weeks, that helps a lot, since it increases mucociliary function, it increases sputum clearance, it reduces airway reactivity, it increases sputum production, and if a cessation is more than 6 months, then uh, patient's pulmonary reserve remains similar to as of non-smoker.
Okay, good. So, if the patient has already stopped smoking since last 6 months, then we can go ahead. But still, we have to, it's always better to optimize the lung by instead of spirometry, right?
Yes, ma'am.
So now we know most of the things about this patient. We know we have given the preoperative orders. Now this patient is coming for you after stopping the smoking also. All the investigations are supposed normal, right? Now how you will proceed for it and which type of anesthesia is preferable for you?
Choice of anesthesia can be compared in context with neuraxial anesthesia and versus general anesthesia. Uh, in case of neuraxial anesthesia, increased vascular flow, reduced chances of DVT due to increased fibrinolysis, reduced chances of pulmonary embolism, reduced surgical blood loss, reduced post-operative cognitive dysfunction. No airway instrumentation is present. Post-operative analgesia is there. Hemodynamic instability is there. Uh, important negative points for neuraxial anesthesia are hemodynamic instability. Technically, it is difficult. In case of epidural anesthesia, in that we face a problem of increased amount of osteophytes, making it difficult for us for entering the epidural space. Epidural space is also reduced in this case, and flow of CSF is also reduced. In case of general anesthesia, there are controlled hemodynamics. Increased duration of surgery can be managed. Greater patient acceptance is there as compared to neuraxial anesthesia, and impairment of neurological examination. Uh, in intraoperative management, we'll start with monitoring with oxygen saturation, heart rate, blood pressure, temperature, urine output, bispectral index, and neuromuscular monitoring is also desirable.
Uh, Nikhil, you didn't tell me, so finally which type of anesthesia you will prefer in this patient? What you will go?
Ma'am, I would like to prefer combined spinal epidural anesthesia.
Why?
Ma'am, because it will give us uh, benefits such as increased vascular flow and reduced surgical blood loss, as well as by putting epidural, we'll also get an edge of hemodynamic stability. We can prolong the surgery as needed. And
Okay.
we'll also have a benefit of post-operative analgesia.
Analgesia. Now talking about the analgesia, how you will manage the perioperative pain in this patient, intraoperatively and postoperative. Intraoperatively, you have given spinal, cases being done in spinal. What drug you will prefer in spinal?
Ma'am, I would like to prefer hyperbaric bupivacaine as a drug for this case, and intermittent boluses of epidural of bupivacaine hyperbaric 0.25% or 0.625% can be used for intraoperative analgesia and postoperative analgesia.
Any additives?
Ma'am, we can use fentanyl, which would be a safer option in this case.
So we can go for a low dose of bupivacaine with some additives to prolong its action,
Yes, ma'am.
right? And epidural if required. Otherwise, we can go for post-operatively as a pain relief.
Yes, ma'am.
What are the other modalities you can use for post-op analgesia?
Ma'am, we can also use paracetamol 1 gram for post-operative analgesia. We can use regional blocks such as pericapsular nerve group block, facial LACA block, femoral nerve block, and we can use these blocks, lumbar plexus block.
So, specific goals during the operation?
Ma'am, we will try to avoid hypertension, tachycardia, and we would like to maintain an adequate fluid by monitoring heart rate, blood pressure, and urine output and blood loss.
Ma'am, if I may ask a question. Nikhil, you said that spinal epidural is technically difficult in these patients, in the elderly patient, as the spine is fused. So how will you be able to overcome those limitations? You have a patient in the OT, you have electively posted a patient, and you, on palpation of the spine in the preoperative assessment, you found that the spine was not good palpable. You had a feeling that it would be technically difficult spinal. So what are the things that you can do to ensure to increase your success rate of spinal and epidural in the operation theatre?
And for this, to overcome the difficulties while putting the spinal anesthesia or combined spinal epidural anesthesia, we can go for sacral X-ray, lower spine X-ray, or we can also use USG guided. We can put USG guided spinal and epidural anesthesia, and we can also put emphasis on proper positioning of the patient while we put the put the regional anesthesia, and
Okay, this question has been asked by one of our audience also, that the elderly patients have a lower pain threshold. So the moment you try to position a patient with a femur fracture for spinal, you want to put the patient in supine sitting position, the patient will have severe pain. So are there any modalities that you can use to decrease the positioning pain of the patient for spinal?
such patients we can also give femoral nerve block so that patient gets comfortable to give the positioning, to give the proper position, and we can put the regional block and with proper ease.
Yes, as is being
Facial
pointed out,
LACA block as well.
facial iliaca block, femoral nerve block, even low dose opioids like 25 to 30 microgram of fentanyl can be given IV before positioning of the patient for spinal to improve the success rate of our spinal epidural. Okay. Nikhil, after we have we have completed the case, are there any specific complications that we're anticipating in this case that is not related only to the geriatric age group, but the fracture of a long bone in itself?
Ma'am, complications specific to this case are fat embolism syndrome, DVT, and pulmonary embolism. For fat embolism syndrome, Gert's criteria for diagnosis is there. Major criteria being respiratory insufficiency, cerebral insufficiency, potassium, rash, pyrexia, tachycardia, retinal changes, fat microglobulinemia, anemia, thrombocytopenia, and increase.
Okay, if a patient lands up with fat embolism, how will you manage that?
Increase, yes, sir.
How will you manage the fat embolism?
With this, we conclude this session. House is now open for question and answer session from audience.
We hand over the session to our screen coordinators.
Dr. Parvati, just see whether there are any questions in the chat box. Madam, there are some, we can just see if there are any questions in the chat box. So I cannot see any questions in the chat box. There is one question. There is one question. How to diagnose FES intraop, fat embolism syndrome intraop?
Ma'am, there is a
Can you unmute? Yes.
Thank you, ma'am. Ma'am, there is a very typical feature of fat embolism syndrome, that is facial rash, that can be observed in over oral mucosa on axillary region, and other observations that we can make are pyrexia, tachycardia. These are the things that we can observe during surgery intraop.
Okay. So right now I can't see any more questions. Yeah, I think Dr. Mohan Pathak has asked, what are any drugs to treat fat embolism?
Ma'am, we will go ahead with symptomatic treatment.
Like
ma'am, 100% oxygenation, followed by PCM 1 gram, and we'll manage the tachycardia with probably beta blockers.
Have you seen any case of fat embolism? Dr. Shruti and Dr. Nikhil?
No, ma'am, not yet.
Have you seen any case of embolism during this long bone fracture surgery?
No, ma'am, we haven't seen.
Fortunately, you have not seen. Okay. So if you have a case of embolism, what will be the clinical symptomatology?
Sorry, ma'am, can you repeat the question?
If you have a case of embolism intraoperatively, what will be the clinical symptomatology? Symptoms, what will you see?
There will be tachycardia.
Symptoms and signs, clinical features.
There will be tachycardia. There will be sudden patient will complain of sudden restlessness.
Breathlessness, okay.
Shortness of breath.
Yes, answers are coming in the chat box. Hyperpyrexia, sweating,
hypoxia,
drowsiness, altered mental status, yeah. And fall in saturation. Somebody also has saying rashes, hypotension, disorientation, so many things.
Hello, ma'am. Good evening.
Yes.
Ma'am, I am Dr. Anand from Ludhiana. I would like to add something in the
Please,
fat
sir,
embolism syndrome.
Please, sir, please add. Please add your experiences.
Thank you. We had a recent incidence of fat embolism intraoperatively just 10 days back. She was an elderly patient undergoing hip fracture surgeries. And I would like to tell you that the patient suddenly had a desaturation and followed by hypotension, and with altered sensorium. All the three features, they came all of a sudden. And there was some medical problem also with the patient. So the surgeon thought that this is some medical issue. But as the anesthetist was present on the side, it was immediately picked up. Saturation was controlled, BP was controlled with the fluids and inotropes, and patient shifted to the recovery. But after 4 hours of surgery, patient did not regain the consciousness. First, we thought that it is because of some analgesic we have given parenteral. So, but it was not the case. By the evening, patient was sedated. She was responding to the deep painful stimulus. But pupil were normal. All the reflexes were normal. Nothing was coming out. So we got a CT done. CT came out to be normal. Then we convinced the radiologist to get an MRI. The MRI showed multiple thromboembolism in the brain. There were multiple fat globules were present all over the brain. So it was a limited MRI scan done, and we made the diagnosis. Then earlier we thought that it may be a local anesthetic reaction or it is a thromboembolism. For local anesthetic reactions, we started lipid infusion. But as soon as we got fat embolism syndrome picture in the brain, immediately we stopped it and we started on steroids. They rightly said that there is no definitive treatment of fat embolism syndrome, but you can add steroid to reduce the cerebral edema, because altered mentation is one of the rare sign with less common sign compared to the hemodynamic instability, but it can present in some patients. So we started the patient with steroids, we intubated the patient prophylactically, ventilated the patient. Now still the patient is with us, and she is recovering. She is neurological recovery is slow, but she is maintaining her hemodynamics, and daily one by one she is improving. But she did not have any other signs, neither the petechiae. We could not see the oral mucosa because she was not in the full mental status, and we prophylactically intubated. But other thing I would like to add here is, don't start heparin. To a patient of fat embolism, please don't start heparin, rather start steroids, because the literature says that heparin also causes lipolysis. The low molecular heparin or the fractionated heparin, that also causes lipolysis. So it may increase further chances of thromboembolism, fat embolism. So the treatment for choice in fat embolism and pulmonary embolism is different. For fat embolism, you go for steroid and supportive measures. For pulmonary thromboembolism, you go for low molecular weight heparin plus all the supportive measures. Rest of the things you can have to wait and watch.
Wonderful, sir. Very, very nice. Very interesting case you have
This is
presented.
Ji sir, ji sir, ji sir.
About that, the going for the fat embolism in the brain.
Ji.
So I think the globules must have been very, very of minute size.
Very minute size. I can send you
which must have crossed the pulmonary arterial barrier in the lungs.
Yeah.
The left side of the heart and going to the brain. So very minute showering, I think, must be.
It was a minute showering. It covered whole the cerebral hemisphere, both sides. All the lobes it covered. We got also surprised. We have seen fat embolism many a times, but it comes and it goes in the next 12 to 24 hours. Patient has tachypnea, tachycardia, restlessness, but never disoriented. This kind of picture we have also seen first time to a elderly female patient.
There's a micrometer size, basically. Micrometer.
Size. It was micrometer, sir. It was micrometer. Even CTs did not pick it up. It picked up only MRI with the implant. We had a very difficult time to convince the radiologist to get an MRI in the so much early implanted patient.
You must report this case. Write it down the case report, letter to auditor, and report it.
छपवा दोगे सर?
नहीं, did you have to work hard? You will get it done by yourself. I am out of the journalism now.
ठीक है सर. ठीक है जी, we will write it down.
Thank you, Dr. Naresh.
जी सर, जी, thank you.
So,
Thank you, Dr. Naresh. That was a really good case scenario that you could discuss with us.
Thank you, ma'am.
Anybody? Yeah.
I think Dr. Mohan Pathak has put the treatment there for the fat embolism as 20% albumin. Right? So can you tell us how it helps?
Intralipid, madam, intralipid.
It's 20% intralipid, no? It's not albumin. Yeah. Okay.
Intralipid is not for fat embolism. It is for local anesthetic toxicity. If you are suspecting local anesthetic toxicity, then give intralipid. If you are suspecting fat embolism, they say that it may, because lipids and fats go side by side, so it may potentiate the chances of fat embolism. If it is going on, the valves are open, the vessels are not strong, there are some shunts in the systemic circulation, so it can further potentiate for fat embolism. Intralipid is for local anesthetic toxicity if you are suspecting. I'm sorry to differ. I just read a detail in the last week only. So that is why I remember the things.
Basically, the physical mechanism is that whenever the fat globules are there, they are obstructing the smaller arterioles or the smaller arteries. Basically, you are causing the obstruction to the blood supply.
Yes, sir.
More or less is restoring the blood supply at the earliest. When the globules obstruct the pathway, there is definitely going to be inflammatory reaction. When you are suddenly causing to the narrow end, or what you call that bottleneck of the systemic circulation, so there definitely going to be an inflammation. You have to tide over that inflammation. You have to restore the blood flow. That is should be the basic primary treatment. And now, how that fat embolism is causing the damage, you have to decide the treatment. I think for this type of cases where the arterioles are very narrow, and inflammation is there, definitely the steroids are definitely going to happen. They are going to treat the patient. It's happening, and we are experiencing it every now and then whenever we are going to get the cases of this knee replacements or hip replacements with the cementing and everything. We are always ready with the injection of the steroids. So that means whatever happens, the literature may or may not support the things fully or convincingly, but we always depend upon the steroidal injection for any type of eventuality in these cases. And it definitely, helps also, aisa nahi hai, but the reported and the unreported data may not substantiate the real value of the steroids in these cases. But when it comes to a patient safety, we have to give the medicines which are available, which are cited by literature, which are really helpful. So steroid, either hydrocortisone or dexamethasone or whatever you are going to take, it is always useful, beneficial. We should not deny those to the patient. We are working for the patient's safety, not for our self-glory or whatever the experimentation in these patients. So whatever is the definite treatment in these cases, go for that.
Yes, sir.
Thank you, sir.
I just have a question. Like, can we go in for transesophageal echocardiography also to detect the fat embolism?
That is a transesophageal echocardiography is just basically to detect the load on the cardiac tissue. On the lungs mechanism, I think the focus is more important in cases of the lungs. Whatever you are feeling, whatever you are going to diagnose in the lungs. The echocardiography, the transesophageal is more if the right side or even the left side, anything is involved. So that is definitely going to help. But for ultrasound, when it's fat embolism, fat globules are lodging in the alveoli or whatever you call the smaller arterioles or arteries of the lung parenchyma, you have to go for the focus. That will definitely help to some extent. But again, it is not going to change the treatment pattern to that much larger extent.
That will help in the early diagnosis only before the patient. Yes.
Parvati, any more questions? I think which must have gone, must have missed.
Yes, sir, we have a few more questions in the chat box.
One by one.
Yes, sir. Dr. Sakshi is asking, what are the preventive measures for fat embolism syndrome, sir?
Shruti, I think you should answer. Unmute yourself. Nikhil or Shruti, anybody, you can answer.
So fat embolism syndrome can be prevented by taking earlier precautions, such as enoxaparin can be used 12 hours before the surgery.
Just one preventive measure.
Enoxaparin will not prevent the fat embolism. It will prevent the thromboembolism. Fat embolism, you have to keep the vessels filled all the time. You have to keep the intravascular volume high so that none of the fat globules enters into the circulation. When they do the cementing, they increase the intracavitary pressure. So keep the vessels filled with the IV fluids. So then the fat embolism is one measure that can prevent the.
And most importantly is the a very vigilant anesthesiologist. I
Yeah,
think
very
by the first
vigilant.
time you detect even a minute hint of fat embolism, you have to stop there, think of all the measures before proceeding forward with all the surgical, because that particular step may have been causing the load in the vessels, or which is causing the fat embolism. So you have to see, you have to be very vigilant, you have to keep a pace up with the surgeons, orthopedicians, steps, where it is actually causing I think the vessels must have opened at particular juncture, particular place where the fat embolism is taking place. So I think the early diagnosis can, really help the patient survive this episodes of fat embolism on the table. That's
And
the most
and the mortality is 40%, sir. Mortality with fat embolism is 40%.
Is a very difficult, and especially in the young patients. That
in the young patients, very right. And difficult to explain to the attendants also. Patient, we did not took the consent for the attendants for that fat embolism will occur or such kind of event can occur now, but we have just changing the practice and asking the consent for such kind of uneventuality.
Yeah, with the
for
long
joint
bone
replacement.
For the long bone fractures or joint replacements, this consent should always be placed. I think everybody in the India, we are. I think it's a protocol, general protocol for the long bones and for the replacements. The consent for fat embolism should be in every sheet.
Yeah, sir. अब we are going to take it. हम नहीं ले रहे थे, sir. नहीं ले रहे.
Dr. Mother, you want to say something more?
Yeah, I just wanted to, like whatever sir presented his unusual case just now. So that case did not have any petechial rash, he said, right, sir?
You're asking me? You are asking me?
Yes, sir. Yes, sir. You didn't. Your case did not have any petechial rash.
Yeah, he did not have any petechial rash. We just try to find out.
Yeah.
But actually, she had only altered sensorium. She was not improving.
Yes, yes. So that's what, because in the diagnostic criteria for fat embolism, this petechial rash is said to be one of the major criteria actually.
That is the clinical diagnosis.
Yes,
but once it has come to the MRI, then everything got filtered out. So the management totally changed.
So that is what. So without one of the major criteria, you were able to diagnose. That's a very important thing over here.
We were hitting here and there because we were not able to find out the reason. We have not given any sedation, not any opiates, but patient is not getting up for after 8 hours of surgery. Pupils are equal size, reacting to light. Reflexes are normal. So it was very small.
That's why I told it's better to have the case reported, because when you are going to report it, you will be finding more literature on these type of things happening around. And I think worth reading also. And somebody asking about the ABG in patient who is desaturating. Naturally, that if the patient is desaturating, it's ideal if you have a facility for ABG, go for it. That will be your just baseline at that particular moment. Your future treatment, your further treatment depends upon that ABG finding, because that is very, very important. In the beginning, you should always do ABG.
इसकी की थी हमने ABG भी इसकी सर ठीक थी. We even sort of
Dr. I am answering one of the questions. Asking that person who is desaturating.
Yeah.
I was answering to that part in the ABG.
Yes, sir.
Please, Dr. Rui, you want to add something more?
Yes, so cerebral insufficiency is one of the major diagnostic criteria for fat embolism and GERD's criteria. The fact that the patient was not waking up, the pupils were of same size, and yet the patient was not waking up or not responding to command is one of the presenting symptoms in fat embolism. In the slide that we have shared, cerebral insufficiency has been mentioned as one of the major criteria for fat embolism and GERD's criteria. Presence of
Yes,
only one
yes.
major and two minor criteria correspond to the presence of fat embolism in the long bone
Mainly,
fractures case.
yes, mainly basically when I think both the factors, the hypotension as well as the minute emboli, even if they go to the brain, or frontal cortex is going to be compromised. Circulation to the frontal cortex and even to the hypotension. So that is definitely going to cause the disorientation, the altered sensorium. So many things are there. That's why a definitive criteria for those things. Parvati, any other question you are must have?
So we have another question, sir, regarding the bone cement implantation syndrome interrupt, sir.
Which one?
How to diagnose the same.
How
Bone
to?
cement implantation.
Can you repeat? Bone cement syndrome.
Yes,
I
sir.
think the cement quality, whatever we are getting nowadays, it's a very high quality cement. I think whatever they come with the implants, people are very careful. The surgeons are also very careful. Even the implant may be of a, that lower quality, but the cement coming is always a good quality nowadays. And same thing, whenever the things are happening, the bone cement syndrome, again, the symptom is the vigil of the anesthesiologist. If the patient is under regional anesthesia, you are going to have a bone cement syndrome. The time they open the packet of the cement, you should be very, very careful about the monitors, that the hemodynamic parameters at that particular moment. Any deviation, a gross deviation of more than 15 to 20% is definitely, that means your patient is undergoing a bone cement syndrome as soon as it is inserted into the, the surgical area. So it's a vigil, early vigil, I think is very important. And again, I think the definitive measures, whatever you can take, again, that maintaining the hemodynamics, the blood pressure, giving supplemental oxygen to these patients. Again, you can give some, the steroid, some anticipatory steroid. Till there's no definitive role that they're going to prevent the inflammation from the cement syndrome, but it is very, very helpful. I'm telling you, wherever I have encountered these cases, it's not that every case will go give you a full-fledged symptom, a full-fledged scenario of a bone cement syndrome. It is always a variation from a very minute to the full-fledged symptom. There's a lot of variation in between those cases. But whatever the prevention you can do at that particular moment is definitely going to help you out.
Sir, can I add 2-3 things more for the audience?
Yeah, please, please.
Please don't get bored up. Sir, इसमें ये था कि there was a contradictory between the surgeon and the anesthetist also, because the surgeon says that this is not a bone cement syndrome, this is a hypoxic damage. Because he just saw the monitor and saw the patient is desaturating up to only 80%, patient went down, not even 60, and becoming hemodynamic unstable. So he was of the opinion that the hypoxia occurred and it was a negligence by the anesthetist. He just, with due respect to him also, he just tried to focus down the guns toward the anesthesia side, care of the anesthesia, that they were not up to vigilant, the hypoxia was happening, they were not knowing. So we were asking, on that day we kept quiet and we were just trying to find out what happened. So once the clouds were clear, then we made out a medical board and then we explained everything. The hypoxia occurred because of the fat embolism syndrome. If there is no fat embolism syndrome, the hypoxia would not have happened. So I mean to say, you have to take care of the other team work also, the other surgeon also, who is standing on the behind the other side of the curtains. He may try to, because in practice in private hospitals these things are not very uncommon, that blame game जिसको हम बोलते हैं कि इसकी वजह से हो गया, इसकी हमारा तो सर्जरी ठीक हो गया, तो उसको भी थोड़ा सा ध्यान रखना चाहिए while dealing with these kind of situations.
I think that's a very common thing. What you are saying is keep on happening. I think it has reduced over the years what we used
हाँ
to
जी
hear during our early postgraduate days, where
जी
the
सर
anesthesiology has evolved as a science which is gaining its independence, spreading its wing into different specialties. The
जी सर
knowledge about the surgical procedure is very, very important because it's not just
exactly
that when you are handling a patient, it's not a patient of yours or a surgeon, it's a patient of the hospital. And
yes
patient belongs to patient of society. You are equally responsible as a surgeon is. So anything happening, I think better coordination is always a good thing. And stooping to these things, that means that your individuality or your whatever the knowledge or whatever the things you have gained in your life as a surgeon or as an anesthesiologist, they are not up to the mark. You have to learn
yes
more. When you are
yeah
working as a team, as a unit, the more emphasis should be on the safety rather than blaming each other. And during these type of things, the only thing you can do is exercise the vigilance. Rest, vigilance and maintaining of the hemodynamics. Rest is up to the surgical scene, whatever is happening at that particular time. You cannot entertain much there. It's a equal game. Once the
yes
incidents happens, think that the way you have discussions post you had a medical board. I think every team, every anesthesiologist and surgeon team should sit together after such incidents and think what we can do the next time to at least enhance the safety in such procedure. That is the
जी
way to go rather than just having some egoistic attitude towards
yeah
the blame games.
yes sir I agree sir I agree.
Dr. Ridhima wanted to ask something, say
Yes, sir.
something.
Good evening, sir. I just want to add that apart from the maintaining the intravascular volume, we can also start a low dose inotrop epinephrine or norepinephrine. They also increase it. And as a sir, you said that knowing the surgical timing and procedure is very important. We can have that nowadays, sir. We mix in our institution. We mix cement in a vacuum. That has really helped us in preventing the bone cement syndrome. And intramedullary saline wash is also very important, so that prevention is always better. So I also feel, and I have also emphasized on taking a consent on long bone fractures and not keeping these patients long for the PAC clearance, because as soon as they are mobilized, the chances of bone fat embolism or pulmonary embolism are decreased.
Definitely. There's another question. Ruhi, you have already answered that the comparison between the suprainguinal fascia, iliaca block, and the femoral block alone. So I think the answer is equally good. The
Both of them
pain,
are equally efficacious. The
yeah,
pain is lower in the group with the
for the
FICU.
positioning. Because once
Yes.
I think you have achieved that goal, the positioning is definitely, and if you are well versed with these techniques, it's going to be very helpful for the patient, very helpful for the anesthesiologist, very helpful for the surgical team also. Because that is a very scenario, very, very painful. The patient, frown, the patient panics sometimes because of the pain and all those things. So this is a good technique. And definitely we are working, striving towards the patient's safety and excellence in our delivery services of anesthesia. These are the good things. Rest, I think, the choice of the anesthesiologist also, they are well versed with which technique. That is very, very important. You cannot exercise all the techniques. You cannot just coming up with that. I want to give this one block. If you are better handling the femoral nerve block, if you are well versed with it, I should go for it. Parvati, any other questions?
There is a question on any contraindication to bone cement, putting bone cement.
Do you remember any contraindication? I also don't remember much contraindication except the
Era, I think it is pregnancy and pregnancy, lactation, and history of allergy to
allergy
aminoglycosides.
only I can remember.
Allergy to
Pregnancy,
aminoglycosides, they have cross sensitivity to bone cement.
how's pregnancy is the contraindication? Pregnancy, we don't do these type of procedure unless an emergency is
Some
there.
types of bone cement.
So
And
then I will ask
urine.
another question: is how the placental barrier is going to oppose that cement flow? That's another question will come if you will talk about the pregnancy, if it's a contraindication, how much the placenta allow the semen to cross the.
No, it is mentioned. And also
That's why, no, one way
Hmm.
mentioned, but I think there is always a logic behind these things. So that's my question to the people who have written those books and those things. So whether the cement will cross the placenta also if emergency surgery is being done in a pregnant patient. Dr. Parna wanted to answer this question, I think. She has raised her hand. Yeah, Dr. Parna, please answer this question of mine.
Yes. Good
The
evening,
placental
all.
barrier and the cement,
No,
bone
not
cement.
placental barrier. Regarding the contraindications, I was just saying that maybe, patients who are very elderly, in those patients, sometimes the surgeons prefer to do non-cemented prosthesis. So, very elderly patient. So, maybe that is a relative contraindication. So, very
And that
elderly
is, I think, just to avoid
Yes.
the complications
Yes,
associated with the
bone
cement, they
cement
do those things.
embolism. Yes, yes.
And there are other
And
surgical indications also not to use the cement. Those are surgical indications, especially in the elderly.
yeah, yeah. And I just wanted to, share my experience. I had two cases of one was fat embolism and one was bone cement embolism. So, like one lady was I think around 85 years old, and she had massive fat embolism during the surgery. So they were doing bipolar, and like suddenly on the monitor, I could see that patient's heart rate started dropping, and then she was not responding. And immediately in lateral position only, I secured the airway. I put in the LMA. Then we had to resuscitate the patient, but patient came around, and she went home after 20 days. So vigilance is very, very important, especially when they are doing cementing. And secondly, another patient was, I think she already had massive fat embolism because she came on table, I think, after 2-3 days. And her saturation was 93, 94%. She was also elderly patient. So, and her chest was not, very optimal. She was not optimized well. So her SATs were between 93 to 94, and the urine was slightly white colored. Then later on, once that fat embolism occurred, after that I went back and read up. So always note the color of the urine. If it is whitish, that means patient has already started developing fat embolism. So these patients also can have, fat embolism during the intra period. So these are just, my observations and sharing my experience. Thank you.
Basically, all these contraindications, relative contraindications, there has no been studies, randomized controlled trials, whatever the cement industry is putting up for the product to go, they just try to be little on the safer side, putting those patients, the whatever the thing, the older patient or the whatever you call the pregnant patient. All these are relative contraindications. They have not been established as such. The data is just to support the pharma product whenever they put a contraindication so that they are in the legal soup tomorrow. So that is from the pharma side. But when they come to the textbook, you won't be getting a literature for these contraindications. Wherever I think we use, maybe isolated one or two case reports may be there, but those will not substantiate the real contradictory nature of this bone cement. Anyway, whatever they have been projecting, they are depicting in the literature, I think the manual comes with the cement. It's only those things which you go ahead with that. I think it's fair enough to go with those contraindications. Anything else? Parvati, anything
So one
else?
more question we had in the chat box was, how do you differentiate intraop, fat embolism, bone cement embolism, and pulmonary embolism and air embolism intraoperatively?
Dr. Madhuri raised the hand to answer. Yeah, Dr. Madhuri.
No. I was wanting to tell Parna
No,
that the pregnancy, because they have done studies and it is still a topic of research, that if you inhale the polymethyl methacrylate, it can cause fetal anomalies. That is what.
Dr. Madhuri, please, these studies, they are
Okay. No,
one
but
or two supports.
it's
We can't.
mentioned in the literature.
Yeah,
Okay.
yeah. I'm telling you, the
Okay.
pharma products, the pharma company, they are all on the safer side. That's why
Okay.
these things are keep on happening, and the whole literature is of Western culture. In India, whatever they do in America, we go almost around 10 times the surgeries in India. We so many patients are there, so many people inhaling, so many, because in the OT, when you are doing the cement, you inhale so much of the cement, and I find it always good. I don't find that any anomalies causing in our body also. It will be a long-standing surgery for a long 30 years period when you come to know. So what the real harm is done by the cement smelling or sniffing. So anyway, I think you wanted to answer that, Parvati. She just questioned the thing.
Okay.
Differentiate between.
You want me to answer the next
Shruti or
question?
Nikhil, you want to answer?
Hmm.
I think they are getting a little panicked with the questions.
No, I can answer. What
Repeat
is
the
that?
question. Parvati, repeat the question, please.
How do you differentiate fat embolism, air embolism, and pulmonary embolism intraoperatively?
A very good question, actually. We should give some prize to the person. Differentiation. Now, it's depending on Shruti and Nikhil, then Dr. Akansha, Dr. Madhuri, there are three people to answer.
Yes, I'm ready.
Very interesting answer. Very interesting. Very simple answer.
Yes. Yes, you can start, Doctor, this one.
Shruti and Nikhil.
Starting from Shruti. Yeah.
We will help you out. Don't worry.
So for pulmonary embolism, we'll go for blood. We'll see for blood clots if present.
See.
First.
Anyway, think over it.
Let's go systematically, starting from the clinical features. Let's start. So, what will be there in fat embolism? What will be seen in pulmonary thromboembolism, and what will be seen in air embolism? What will be the signs and symptoms?
Embolism syndrome, we'll get one of the three major factors.
You have already told that, yeah.
Potential rash, other one is respiratory depression, and the cerebral insufficiency. One of them will be getting. For in case of pulmonary embolism, get symptoms like chest pain and followed by breathlessness, shortness of breath.
Yes.
Hypertension.
Yes.
Tachycardia.
Yes.
Good. It's like a viva being answered. That's nice to hear. Anyway, don't, because you are a PG student and we like to hear like that only. It's not that you will be delivering the answer like expert. You keep on answering, think, and you keep on answering. We want to build your confidence.
Simultaneously, you can tell about the pulse oximeter findings and also the end tidal CO2 findings.
Yeah.
In all the three conditions. Very important, that is. So what will be the pulse oximetry findings in fat embolism, in thromboembolism, and in air embolism? Next, you tell the end tidal CO2 findings. Very simple. It's going to be desaturation on all the three, right? Dr. Shruti?
In fat embolism, the EtCO2 findings would remain in normal range, I believe. It's fat embolism.
Okay. Then what about in thromboembolism?
Thromboembolism, if it is pulmonary embolism, then the EtCO2 will rise.
And what will be the shape of the curve, the capnogram? How will it appear? I think Dr. Ruhi can add to that. You can help them with what will be the capnometer findings, capnometry, and the capnogram in the thromboembolism.
I think it would be sudden flattening of the EtCO2 graph in both pulmonary embolism and the air embolism. Whereas in the fat embolism, the Kaplan graph would remain would be within normal range and maintain its graph.
Yes.
I think so. I'm not very sure.
And what will be the diagnostic criteria of air embolism?
Rather than asking,
very
you can
simple.
answer
Air embolism you can see in any condition.
Madhuri, you can answer to save the time also.
Yeah, in air embolism, what is most important? On auscultation, you will hear the malleable murmur, right? And what else? Only male wheel murmur? Anything else?
It is not common always, but you can
It's
hear,
not
but
common,
not
but
in
you
every
can.
case.
Yes. And the treatment is going to be symptomatic for all three. And in addition, what else for fat embolism? For air embolism? You have to give the Durant's position, right?
Yeah.
Huh? Unmute
Yes.
yourself. You have to give the Durant position. Then
Ma'am, we
you
have to
have
give
to
branch position
pass
and
the CVP line. Yes.
ma'am, we
And
need to
aspirate
get
out some the
Yes,
air,
aspirate the air.
embolism.
Then
side with
Then, of course, you have to give inotropes and all that.
Symptomatic
Hemodynamic
management.
support, intubate, ventilate, all those things. And fat embolism, you have already discussed the treatment with what is that? That is already discussed. What drugs you're going to give? IV heparin and all.
Ma'am, if
Actually,
I
in
may
the
add,
initial stages, Ruhi, just I'm telling you, initial stages
So-
are very difficult to differentiate. So, what is the most important at that particular time, whenever either it's your ETCO2 is falling, or if you have put an ETCO2, if the patient is under regional, you may not be having a ETCO2 monitoring properly done, because that the side stream or even the central analyzer may not give you the accurate reading. So I think ETCO2 you may not be able to analyze properly in the initial stages when the patient is under regional anesthesia. So whatever the features are there in the early part of this embolism, whether it's air embolism, fat or pulmonary thromboembolism, the most important part is the maintenance of the hemodynamic parameters, because that is going to decide the future morbidity and mortality of the patient. If you let that golden time pass, it is going to be a very crucial for patient to come back normal. Diagnosis can be done later on, but initial part, as symptomatic as what it comes on the table, whatever the monitors you are basically the parameter you are seeing, where parameter is getting the range, you have to rectify those parameters irrespective of whether it's a pulmonary embolism, thromboembolisms, or even it's a fat embolism. So listening to that, then I think other diagnostic studies can continue. The diagnostic evaluation can continue. Initially, you have to ensure the patient safety and hemodynamic parameters. Am I correct, Dr. Madhuri?
Yes, sir.
Thank you.
And I think
Now,
a simple urine test also can help. You can have a fat globulin in flat embolism, no? That is not present in here. And use of focus is very important. At ultrasonography, you can put it and see the embolus that, in the lung, that you can also do.
Yes. And
that is for
doctor.
diagnostic purpose. Diagnostic can come later on, but the initial part is to sustain the patient's hemodynamic stability.
And on the table, it is very difficult to find out the urine fat
Very
globulins.
difficult sometimes.
It
Later
can-
on, you can go for the urine examination also, the fat globulin in the urine also you will be encountering in the fat embolism. So many things are there. But by the time that you encounter those things, the patient get deteriorated, and these are geriatric patients more importantly. They have very, less reserve. Just like the pediatric patient, geriatric also have got a less reserve. They're in a compensatory states at many of the hemodynamic endpoints.
Initially, the symptoms will be almost the same in the beginning.
Any more question, Parvati?
Nothing from the chat box, sir. Audience, if you anybody has any question, you can raise your hand
Then I
and
think
ask
it's a
them now.
time to felicitate our faculty, and I think my screen is visible.
Yes, sir.
Yes, it is visible. Yes, sir.
Yeah, yeah.
Visible. Yes.
So,
Yes, sir, it is visible, sir.
It's a small gesture from the ISN national side, from the president, secretary, and academic chair. We are felicitating our esteemed faculty today, Dr. Mahima Batra. She's a professor and head, and her team, she has made a good effort with her team. So thank you, madam, for holding this class. And Dr. Akanksha, she is another.
This opportunity.
Yeah, ma'am, always welcome. And Akanksha, you are equally very hardworking. So thank you very much for building the entire faculty and the students with you.
Thanks a lot, sir. And we really enjoyed and had a very amazing session.
So Ruhi is, I think, more well connected with the PG. She's the connecting link between the faculty and the PG
the
students.
youngest most in the chain.
Yeah,
Thank you for
She's
the
our link.
opportunity.
Yeah. And Shruti
Looking
and
forward to attending.
this one, our Nikhil, they were both appearing a little bit, typical. They were prepared for this examination today, like a viva in the finals. So I think good. They have got a dress rehearsal. It's a semi-final for them. So they are now almost ready for the finals whenever they're appearing for the final examination.
Thank
And
you so
Parvati,
much.
you have been wonderful in holding this fort as a screen coordinator along with Asta. So thank you very much
Thank you, sir.
for being a good screen coordinator today.
Thank you so much for the opportunity, sir.
And now I think anybody wants to ask, they can ask. So before another 5 minutes are there. Any suggestion or any comment or any question, anybody can ask before we wind up.
Sir, I would like to thank on the behalf of my team, to you especially, and Madhuri ma'am for guiding us so much. Since yesterday, she is helping us out in lots of things. And
So-
definitely Dr. Parvati, Dr. Ridhima, and Dr. Asta. Thanks a lot.
So you have used 30 seconds for the compliment. So 4.5 minutes left.
Sir, तब तक questions नहीं आए ना अभी तक.
Anybody wants to ask anything again? Something good? Or even you can type in the chat box or you can raise the hand, unmute yourself.
Sir, I want to add one thing about differentiating between fat embolism, air embolism,
Yeah, sure.
and the
Little louder,
pulmonary
Ruhi.
embolism.
Little louder,
The-
come near the microphone.
The differentiating between the three embolism intraoperatively is not possible because all the three of them have similar presentation, unexplained hypotension and desaturation, which cannot be picked up, a reason for which cannot be found. What I had read was that the use of TEE is helpful in differentiating between pulmonary embolism and air embolism, because it can be picked up, the air in the RA or the embolus in the pulmonary artery can be picked up by the transesophageal echocardiography. And with the HRCT and CTPA being the definitive diagnostic modality for pulmonary embolism. So when we have to manage the case intraoperatively, we just go by the presenting symptoms of the patient and provide resuscitative care to the patient to manage the time being during the operation theater, and then go for definitive management.
That was what Dr. Madhuri also trying to say about the TE in these type of cases. So diagnostic part is always a very good part for the TE or the ultrasound. They definitely establish a diagnosis, and after the initial treatment, you can go with a further advanced treatment also on the cause-related diagnosis. So
Yeah.
definitely those
Sir,
things
I would
are
like to add, we had done 2 cases on which we have done the on-table TE, and it was showing a clear-cut thrombus. So we manage accordingly. So it was a very nice diagnostic tool on table.
Sir, add on Dr. Ruhi's and ma'am's comments that sometime in relation to the surgery also we can have a diagnosis of suspicion, like the long bone surgeries, fractures, hip surgeries. They are more prone for the fat embolism. And for neurosurgical procedures, sitting positions, and some non-physiological positions, then there are more chances of air embolism. So
Air
that
embolism,
also, but it will
embolism
not,
also.
that will not change the management part, but that the management part will remain the same in the beginning. In the beginning, when you have to save the patient, because mortality the rate is very high with these embolisms.
I think as soon as the treatment is started, as early
Yes,
as
sir.
it started, it
As
will.
early as possible. Yes, sir. Yes, sir. Yes.
Anybody else want to say something? Or we should close down the class here? So everybody is happy.
Your call, sir. Acha topic, Dada. It was a good topic. I joined a bit late. But I wanted to share the experience.
Dr. Mohan Pathak again asking Dr. Low molecular routinely. Sir, I think low molecular weight routinely is not advocated as such, but with a long bone fracture, I think when your patient is going to get immobilized for a little higher time, so better to go for the low molecular weight heparin in these cases. Otherwise, we don't use low molecular weight heparin in such cases, but just for the sake of DVT, and we are using it. But for the presentation, for preventing that fat embolism, for anticipation of fat embolism, it is not routinely recommended.
And more so that there are chances of bleeding for these major surgeries. The DVT pumps are more recommended, especially in these fractures, rather than low molecular weight heparin.
And only for the long standing cases where the patient is going to be bedridden, especially
Yes,
trauma with a
yes.
head injury and a long-standing, So there we definitely go for the low molecular heparin. Otherwise,
Yeah,
it's
definitely.
easily recommended.
Earlier, we used to give low molecular heparin night before the surgery also, like 8 p.m. we used to write it down. But surgeons are not very happy for the hip surgery because they are not using the tourniquet. So they say that there is some troubleshooter ooze when you give prophylactic low molecular weight heparin. So that practice also we could not support much, and there was a genuine reason from their side also.
Definitely,
So DVT fund.
they are going to do surgery, the particular that area where are they going to do the reaming and, the sections, bone
Yes, sir.
cutting.
Yes, sir.
If it
Yes,
keeps on bleeding, the surgical sites keeps on oozing. It's a very difficult part for them.
difficult part. Yes, sir.
So I think it's a teamwork has to be a very, very good in these
Right.
type of cases. And over the time, the things are evolving practices with the more of evidence, more of, the better sense in the
Yes, sir.
medical knowledge. Things are always changing. So it's a
Yes.
keep on it. Dynamics. I think anesthesiology is a dynamic branch with every day.
Yeah, sir.
You are learning so many things. I think no branch has put the wings in so many specialties and subspecialties the way anesthesia has spread its wing.
Yes, sir.
That's why it is making its presence felt. Except in the peripheries where we still our practitioners are struggling with surgical, cases where call the different remuneration and other things are there. Otherwise, the anesthesia in an institution, it's gaining more of importance wherever you
Yes,
are
sir.
heading towards.
You need a lot of academics part also in the institutes. You need a bit 15-20 सर्जन के साथ आपने डील करना है, then
शेर ऐसे ही होता है, शेर तो फिर भेड़ बकरियों के साथ ऐसे ही करता है ना.
सही बात
Dr.
है.
Mohan Pathak want to say something. Let him speak, sir. Then we will wind up. Mohan Pathak, sir.
Our patient had a massive pulmonary embolism after laminectomy, which she had twice arrested and then shifted to the ICU. And after angiography and mechanical thrombolysis helped her, and she was saved. Mechanical thrombolysis was done for her, and she was saved after twice
That must have been
arrested.
a massive embolism. Massive, must be
Yes,
massive.
massive pulmonary embolism, bilateral. Yes.
Then it's have to be a surgical intervention in those cases.
Yes, surgical intervention was done.
Yeah.
Thank you.
I think it was a good class. So I thank everyone, especially the team of the Bhopal Medical College, PCMS Medical College. Is it? Shruti, and unmute yourself. You have to answer. You are the PG students.
कॉलेज का नाम तो बोलो.
अरे नाम बोला करो कॉलेज का.
The People's College of Medical Sciences and Research Center.
Yeah, so that's what I was asking. So thank you very much, the entire team, and all my coordinators, Dr. Madhuri, Dr. Ridhima, and all the screen coordinators, Parvati and Asta. So we'll meet next Monday. This Monday we had a Janmashtami, that's why the class was done today. So next week we will meet again on Monday, 6:30 p.m. Well then, good night and long live ISA.
Thank you, sir.